Before starting my talk, I would like to thank RG Store and respected Dr. Dilip, Dr. Ajit sir and Dr. Sanjay sir for giving me this opportunity to come here and talk with you all. So today my talk is on female sexual dysfunction, and let's start. Desire for sex is an innate human need, and it is the right of everyone to have a satisfactory sex life. Males, they regularly talk about sex, they are very open to it, they don't hesitate. But females in India especially, they hesitate to discuss about sex even in the closest groups. They have a fear of being labeled or judged for their want of healthy sexual life, and they take it for granted that even like once they deliver babies and normal delivery if it happens, they take it for granted that the sexual activity decreases. So their mindset needs to be changed on these things, and they take it that it is normal to have a less satisfactory sex life. Women's sexuality, as we all know, it is very less talked about. There have been so many discussions on male sexual functions, but female sexual dysfunctions are it's the new topic for discussion. And with the cosmetic gynecologists, they are now very hardly working on these topics. They are dealing with especially the functional aspect of female sexuality. And being a cosmetic gynae, definitely, even I am into practice since 16 years of my obs-in gynae practice. But we were dealing routinely with normal kind of patients, and after doing the cosmetic gynae, we really know what's the impact of having a great sex life. And women's sexuality is multifaceted and complicated, and globally 30 to 40% female have these sexual dysfunctions. It can affect at any stage of life, but problems with sex, they tend to definitely increase with age, as we all know. And sexual dysfunction is a disorder that can take many forms and have many causes. It can occur before, during, and even after sex. And contrary to popular belief, the experts say frequency of sexual intercourse has nothing to do with sexual satisfaction. It is the quality of sex which matters. This is a slide which says all women's problems start with men. Mental illness, menstrual cramps, menopause, hysterectomy, and female sexual dysfunction. But I would also like to add to this that males are always there standing by females in time of crisis. Being it a father, I've witnessed fathers bringing their daughters to our clinics with menstrual complaints, dysmenorrhea and all. Husband coming with their wives for her partner issues, and recently I did back-to-back certain laparoscopic surgeries for female gynae issues, and you will not believe that out of 8 females, their sons were they had come with their mothers for their problems. So males, we cannot deny the role of males in our lives. They are there for you every time. Now, sexual response cycle, as discussed earlier, the same phases like males starts with excitement or desire, then plateau comes, then orgasm, and finally the resolution. And the female sexual dysfunction, the definition revolves around these things. There is difficulty in getting that the excitement. There is inability to achieve the orgasm. So the definition revolves around this female sexual response cycle only. It involves problems during any phase of sexual response cycle that prevents an individual couple from experiencing satisfaction from sexual activity. It includes disorders involving desire, arousal, and orgasm. It also includes sexual health, pain disorders, as is discussed by Dr. earlier, dyspareunia and vaginismus. And these all problems have been recognized by Diagnostic and Statistical Manual of Mental Disorders. So the psychological aspect has been taken well into consideration. This is the classification of female sexual dysfunction by DSM-4-TR, that is text revision criteria. Hypoactive sexual desire disorder, it is absence or deficiency of sexual interest and or desire. Sexual aversion disorder, aversion to and avoidance of genital contact with a sexual partner. Then female sexual arousal disorders, inability to attain or maintain adequate lubrication and the swelling response of sexual excitement. Then female orgasmic disorders, delay in or absence of orgasm after a normal sexual act, excitement phase. Then dyspareunia and vaginismus, already all these points have been covered earlier also. Then female, this is the slide showing prevalence of female sexual dysfunctions. Desire disorders are usually up to 60% to 75% of females. Orgasmic difficulties are like 16% to 48%. Arousal disorders are there in 12 to 64% of females. And pain disorders as high as 7 to 58% of females. And this is a slide showing that there is always an overlap of female sexual dysfunction. Usually, like if it is a vaginismus, may be associated with orgasmic disorders or sexual desire or disorders. In even some of the females, all of the problems can be there. There are certain milestones in a woman's reproductive history which can increase the risk of sexual dysfunction, like infertility, patient who has undergone oophorectomy, pregnancy loss, and menopause. As we all know, there is genitourinary syndrome of menopause and vulvovaginal atrophy happening in that particular age. Then these are again risk factors like hypertension, smoking or substance abuse, hyperlipidemia, and history of previous pelvic surgeries. Causes of female sexual dysfunction are classified as physical, psychological, and psychosocial, and surgical. Coming to physical causes, these are the same problems which affect male sexual functions also. Diabetes, heart problems, neurological disorders, hormonal imbalance, chronic disease like liver or renal, arthritis, urinary incontinence, substance abuse, pregnancy and postpartum, this is like especially for female pregnancy and postpartum states because of prolonged lactation, and certain medication which influence the desire, arousal, and ability to attain orgasmic state. Then psychological or psychosocial causes, stress, anxiety, cultural influences and religious taboos, sexual performance concerns, marital or relationship issues, partner's sexual health, depression, guilt, and any history of past sexual or physical trauma. The surgical effects, it has been seen that if female is a case of gynecological malignancy, there is 74% reported decreased desire and 40% patients reported dyspareunia. And like if she is a breast cancer survivor, she'll 21 to 39% incidence of female sexual dysfunction are there. And if she has undergone hysterectomy for a benign disease, out of those patients, 30% reported decreased response. There are certain pharmacotherapies, drugs which can increase the risk of female sexual dysfunctions. These have been already discussed in the previous slides, like SSRI, SNRI, tricyclic antipsychotics, beta blockers, alpha blockers, certain diuretics, lipid-lowering agents. Then for females, especially oral contraceptives, estrogen and progestins, and certain anticonvulsants and amphetamines, etc. Certain medical conditions which can increase the risk of female sexual dysfunctions like depression, diabetes, thyroid problems, cardiovascular problems, neurological disease, androgen insufficiency and estrogen deficiency. These, like if she's in case of depression, there will be decreased desire, estrogen deficiency, impaired arousal, and so on. How do you diagnose a patient with sexual dysfunction? We have to take complete history and do the physical examination, and we should do PAP and pelvic examination of patient. And we should ask a proper history, what is the attitude towards sex, is there any past history of trauma or sexual abuse, whether there is any relationship problems, what is the sexual orientation of female, substance abuse history and medical history. Elements of a routine medical assessment for female sexual dysfunction include past medical history, physical examination, inspection of the external genitalia, mono and bimanual examination, and certain lab tests like thyroid function test, hormone profile, and fasting glucose. Brief screening for female sexual dysfunction include there should be a legitimization of the importance of assessing sexual functions of females. It should be a normal part of the usual history and physical examination. We should ask the patient what concerns or questions do you have about your sexual health. If there is none, so we can tell patient please feel free to ask in the future. And if she is concerned, then are you currently, we can lead the questions like are you currently in a sexual relationship? Do you have any difficulty with desire arousal? Like at what stage of sexual response cycle she is facing the issue? And if she is not currently having sexual activities, are there any particular problems that are contributing to her lack of sexual behavior? So we should go into the history in bit detail. Then again, we should address the nature of the problems, how long the problem is there, the duration of the problem, whether it's primary or secondary, whether it's again situational or global, whether she is suffering from relationship issues, whether is there any stress which is causing her to avoid that particular that activity, then whether there are any sexual problems with the partner, and any history of physical, emotional or sexual abuse. Again, detailed sexual history, what was like her first sexual experience, how many partners, approximate number of partners she has, gender and or orientation development, STDs, pregnancy, past history of sexual development, any substance or sexual abuse. Now the treatment guidelines are like education, and education. Like we should educate the patient about anatomy, the functional aspect, and she should be well known about the effects of aging on sexual functions. Then we can give her certain enhancing stimulation by giving her erotic materials, and a patient can be told to do masturbation, and distraction techniques like fantasy and legal exercise with intercourse, encouraging non-coital behavior. Non-coital behavior is like if the patient, the partner, female partner is busy, we can tell her husband or partner to give a massage to the patient when she is in pain during her period. And minimize pain, like this has been already discussed in previous slides also, changing the position, giving some lubricants and warm baths, and if she's complaining of pain, we can give NSAIDs prior to intercourse. Now treatment, hyperactive sexual disorders, it is a bit difficult and it is often secondary to boredom, lifestyle factors or medications can be given. Estrogen therapy may help in some cases, and testosterone use is controversial. Then females who are suffering from sexual arousal disorders, they usually attribute to inadequate stimulation, so they should be encouraged to go for foreplay and use of certain lubricants. For orgasmic disorders, usually response is there with treatment, and it usually happens due to sexual inexperience or lack of sufficient stimulation. And the treatment goal is to maximize that stimulation and minimize the inhibition. Now, for pain disorders like vaginismus, counseling can be done, certain relaxations can be given, and for dyspnea, again, lubrication and certain relaxation exercise for the patient. Now, when is the time to refer a patient of female sexual dysfunction? When there is low physician comfort, there is lack of expertise, patient is not responding to the therapy, and she is a case of complex dysfunction and there are relationship issues, then we should be referred to a sex therapist or a person who is specialized in FST. Now the treatment options on the horizon are like androgen, testosterone, as we all know, it increases the libido, The transdermal patch of testosterone, mostly the 300 microgram one, has been found to be effective in this. Then prostaglandins, they all increase the blood flow and the vaginal secretions to a certain extent. Nitric oxide also works in the same way. We have two centrally acting agents here, dopaminergic and melanocortin stimulating hormones, and then drugs which reduce the pain can be given to patients like gabapentin. Now, my talk will be incomplete if I don't talk about the functional aspect of sexuality, which a woman, a cosmetic gynae can address. Like we usually get this history that patient doesn't attain orgasm during sex, history of lax vagina. So far we were talking about other things. Now these problems are the things which are being addressed by, especially by the cosmetic gynecologists. We are digging deep into the problems which were not addressed earlier. Even during our PG days, we were not told about whether big labia minora can be a problem in patients' sexual satisfaction. And labia, even abnormal looking genitalia can lower the confidence of a female, and she can, it can be a stress factor for her to not to get involved in such activities. So being cosmetic gynae, we have been taught to address such problems which can help the female to increase her confidence, and we can give her proper treatment, whether it's surgical, non-surgical, and it will help the female. Even bulky labia minora, as I told, and low peripheral folds, because it covers the clitoris completely, and sometimes prolapse issues with females. Incontinence, females may have fear of urinary while doing intercourse, so they don't get involved in it. So these are the issues which we usually, we take proper history, vaginal dryness, pain during sex again, and loss of libido. Because now Indian mindset have also started accepting that women also deserve equally great sex life for their overall physical, social, psychological, and emotional well-being. Incontinence usually caused by childbirth, menopause, obesity, aging, and history of previous surgery. Then we diagnose it by cough stress test, and we rule out urine infection by doing a culture in sensitivity. We explain, tell patient to do some exercise and give her medication. And there are new things on the horizon like electromagnetic stimulator. We tell our patients to do diesel exercise, but how many of us we confirm whether the patient is doing it in the right way or not? Because unless we do palpate the muscles, we cannot make out. So and these electromagnetic stimulators, these are like a new concept. So many trials have been done so far, and they have found promising results in urinary incontinence problems, in vaginal laxity, and also in studies have been there in which erectile dysfunction. They are also claiming that electromagnetic stimulator can treat it to a certain extent. One session of electromagnetic stimulator gives up to 1,000 Kegel exercise in 20-minute session. And we do have energy-based devices like laser and radio frequency. And ultimately, if the condition is severe, she can always opt for surgery like theory. Now, lack of achieving orgasm, being as a cosmetic, besides ruling out other problems, we offer patient orgasm shots, which are like totally new concept. We in this we take blood of patient, we prepare PRP, and we inject it at particular sites, the erogenous zones of females, especially the G-spot and certain other like at clitoris and other areas. So this is a new concept. The one shot lasts usually for around 4 to 6 months, and it is showing very promising results for the patients. So like in India, it is Kama Sutra shots. Vaginal laxity also, we can address this issue and give option. We both have both options like non-surgical and surgical. If the laxity is not severe, like we can offer always offer patient energy-based devices like laser or rate of frequency. There are sessions for that. Then if the laxity is very severe, we can always go for surgery. That is surgical vaginal tightening. And vaginal dryness, besides hormonal supplements, the role of laser and RF also comes in this. Then bulky labia minora and long superficial folds. As I told, even during our PGs, we were not aware that these problems can also lead to, can decrease the confidence of females, and they may interfere with the sexual activity. So they are being addressed now and taken care of. We can always do surgeries for such patients. And again, we have non-surgical options, surgical option, and counseling is very important for sexual dysfunction because you tend to rule out so many issues which are there and handle them. Non-surgical options, we have vaginal rejuvenation, vaginal tightening, orgasm shots, and for SUI we have again RF and laser, and this is like postpartum makeover for patients to boost their confidence. And surgical procedures again, vaginal rejuvenation, surgical vaginal tightening, labiaplasties, TOT for SUI, and hymenoplasty and revirgination. This one thing I would like to tell you that we are not only doing hymenoplasties for gaining virginity. Now there is a trend that females are gifting this virginity to their partners on special occasions, like 25th year of marriage anniversary. They are gifting virginity by undergoing hymenoplasty or surgical vaginal tightening. So this is a new trend in the metro cities now. Immunoplasty and surgical clitoral reduction for long superficial folds and perineoplasty. I'll conclude my talk. Thank you so much for patient hearing.
I think that they have absolute. Hello. Absolute. We are going to do a panel discussion now. Okay. That time. Sorry.